Hi guys, in this video we will talk about inpatient management of diabetes. Let's start with goal glucose. For any patient who is admitted to the hospital and you're trying to manage their diabetes, their goal serum glucose should be between 140 to 180. Next one is oral medications. Is it appropriate to use oral medication for management of hyperglycemia in patient? And the answer is the new evidence shows that some medications are okay to use while in patient the oral hypoglycemic. Now we will not go over that in our video. Just to keep it short and sweet, I will mainly go over how to use insulin to manage someone's diabetes while in patient in this video. There's multiple approaches. The most common approach used to manage diabetes in patient is called the sliding scale insulin order set. So let me tell you guys how this works. So when you put a patient on a sliding scale insulin order, the nurse would usually check their blood glucose 3 times a day or 4 times a day. It depends on the hospital and their policy, but most commonly it's done 3 times a day, and they check the blood glucose pre-meal. And in the order set it says that, let's say if their blood glucose is between 200 and 250, give them 4 units of insulin. If it's between 250 and 300, give them 7 units of insulin. If it's between 300 and 350, give them a different unit. If it's between 350 and 400, give a different unit and call the doctor. So the sliding scale insulin is an order set, and the dosing is usually comes in as part of the order set itself, and the nurses should give the dose based on the order. Now what exact insulin we would give the patient in this sliding scale, it's up to you and up to the hospital as well. Let's say the hospital just tends to use a lot of aspart, you may just decide to use aspart, but any short acting insulin is a fair game. You can use aspart, you can use lispro, sometimes you can even use regular insulin for this sliding scale insulin, and the dosing I told you it's a part of our order set. Now a better way to manage diabetes while in patient is to use a combination of a long acting insulin, a short acting insulin, and a sliding scale insulin. The sliding scale insulin works the same way as this sliding scale insulin. The long acting insulin you must often give once a day. Sometimes you may give twice a day, in the morning and at night. If you give once a day, most commonly you will do it at night. And the purpose of this long acting insulin is that it would help to bring the baseline glucose level at a lower than what the patient was staying at. The short acting insulin you give it with meal, and the purpose of the short acting insulin is to prevent the spike in blood glucose that diabetics should get after eating a food. So this short acting insulin the nurse would not give unless the patient has eaten 50 or 75% of the meal. Again, it depends on the nursing policy at the hospital. At my hospital, the nurses would give the short acting insulin only if a patient has eaten 50% of their meal. And how much insulin to give the short acting dose, you decide. And what insulin to use, you decide any of the short acting insulin. Again, you can use aspart, you can use lispro, you can even use regular insulin. And usually the hospitals, they have some recommendation based on what's available to the pharmacy. One more time, long acting insulin most often you're going to give once a day at night. Sometimes you're going to give twice a day at morning and night. Short acting insulin you give with meal, and you give only if the patient has eaten at least 50% of the meal. And the sliding scale, the patient will get this regardless of whether they have eaten or not, and usually it's given pre-meal as well. So you would decide how much insulin to give for the long acting and the short acting. The sliding scale usually comes in as a part of order set. Now sometimes the nurses would page you at night saying that, hey doctor, this patient's blood glucose is 110, there's 20 units of glargine ordered as a long acting insulin, should I give it or not? And your answer at that time should be yes, it's okay to give, because the long acting insulin comes in as a polymer that breaks off over time. So very rarely long acting insulin ever causes hypoglycemia. Now the only time you may want to back down on the dose of long acting insulin is that if their fasting blood glucose is really low, then you may back down on the long acting insulin dose. Another time you're going to get a pace is that the insulin you're going to give with meal, this short acting insulin, the nurse may say that, hey doctor, I checked the blood glucose before the patient had eaten. His blood glucose was 110. There's a 7 units of aspart ordered with meal. Should I give it or not? And again, most of the time it should be okay. You can look back in the history of like how the blood glucose had acted, but the purpose that you're giving the short acting insulin is to prevent hyperglycemia after eating the food, so that should be okay. And the sliding scale, if the blood glucose is low, then the patient would not get it because that's how it's ordered. If the blood glucose is less than 150, the patient usually gets nothing for the sliding scale insulin. Now the way you're going to give someone this regimen of long acting and short acting insulin is by calculating the total daily dose of insulin. For someone who is insulin naive, meaning that they haven't received insulin before, they are only on oral hypoglycemics, you use 0.4 units per kilo per day of insulin. For someone who is insulin resistant, you do 0.5 or 0.6 units per kilo per day. For example, let's say you have a patient who is 60 kilos, then you're going to do 60 times 0.4, and that will be the amount of insulin that you're going to give them per day. And whatever you calculate, half of it you're going to put it as a long acting insulin, and the remaining half you're going to divide it by 3, and you're going to give it on breakfast, lunch and dinner. We're going to go through some calculation. Now at our hospital we usually use 0.2 units per kilo per day, and that's what I have been doing throughout my intern year, and it has worked well. So I just wanted to write this as well because this is what I have been doing. But the official recommendations, if you look at articles, they usually recommend for insulin naive patient use 0.4 units per kilo per day, and this is the dose that you will start on someone with insulin. You would usually change this dose as you keep going through the days. So let's talk about some example patient. So let's say you have a patient 60 kilos, and in this example I'm using the 0.2 units per kilo per day. So 60 times 0.2, you're going to get 12 units. So 12 unit is the total daily dose of this patient's insulin, and you divide this into half, which is 6 unit. So 6 unit you give as a long acting. For example, you can give 6 units of glargine at bedtime, and then the remaining 6 unit you divide it by 3 and you get 2. So you give 2 units 3 times a day with meal. Okay. Another example, assume you have a patient who is 80 kilos and you are using this 0.2 units per kilo per day. So you do 80 times 0.2. So the total daily dose of insulin would be 16 units. Now you divide 16 by 2, you're going to get 8. So the 8 unit you're going to give it as a long acting, and the remaining 8 that makes up the 16 you divide by 3. Now 8 by 3, you can round it to 9. So the 9 unit you can do 3 units TID with meal. So that's how you calculate someone's long acting and short acting insulin regimen. In the previous slide we talked about how to decide the long acting and short acting insulin dose for someone. In this slide we will talk about how to change the insulin regimen in subsequent days. So in summary, the way you change insulin in subsequent days is that you add up all the sliding scale insulin dose that the patient got on the previous day, and the half of it you add it onto the long acting insulin, and the remaining half of it you add it on the short acting insulin. Sometimes some senior and some attending don't like to start a patient on a long acting, short acting and a sliding scale regimen. Sometimes they just want the patient to be on sliding scale insulin for one day to see how their blood glucose does, and they want to add long and short acting only on subsequent days. And this method works for this process too, because if you have not given any insulin for long acting or short acting but you're only giving the sliding scale, again you can divide the total sliding scale the patient received by 2, and one half of that you give them as a long acting and the other half you give them as short acting. Let's go through some examples. For example, let's say on day 1 patient received 12 units of long acting insulin, 3 units TID of short acting and 20 units of sliding scale insulin. Let's say the sliding scale insulin was given as 6 units, 7 unit and 7 unit. So on subsequent day, the way you're going to change the insulin regimen is that the 20 unit of sliding scale you're going to give 1/2 of that as a long-acting insulin. The patient was receiving 12 units as a long-acting before, so you add 10, which is the half of 20, so you're going to give 22 units as a long-acting insulin, and the remaining half of 20 is another 10. You're going to divide 10 by 3. You can round that 10 by 3 to be 3, and you give 3 plus 3 or 6 units TID of the short-acting insulin. Okay, I hope it's clear. Let me repeat one more time. The patient receives 20 units of sliding scale insulin. Half of that you add on to the long-acting insulin. The patient was already getting 12 units of long-acting insulin, and you add half of 20 or 10 on top of 12, so the patient gets 22 units of long-acting insulin. And for the short-acting insulin, half of 20 is 10. You divide 10 by 3, you can round that up to 3, and the patient was previously getting 3 units TID, and you add 3 to 3, you get 6, so 6 units TID. Now let's say on another day the patient was getting 22 units of long-acting insulin, 6 units TID of short-acting insulin, and the patient got 10 units on sliding scale insulin. And the way the patient got 10 units was 4 units before breakfast, 4 before lunch, and 2 before dinner. Then how do you change the insulin on the subsequent day? So the way you're going to do it is that, again, 10 units of sliding scale, half of it you add on to the long-acting. So half of 10 is 5. You add 5 to the long-acting insulin, which was 22. 22 plus 5 gives you 27. So this night you're going to give the patient 27 units of long-acting insulin, could be glargine. And for the short-acting end, you divide 10 by 2, you get 5, and the 5 you split it 3 times a day. So 5 by 3 is 1 point something. You can round that down to 1, or you can round it up to 2. So you're going to give 7 or 8 units TID of the short-acting insulin. If the patient for one example, let's say you did not give any long-acting or any short-acting insulin to the patient on day 1. If the patient is only on sliding scale insulin, and let's say the patient got 12 units of sliding scale insulin, then the way you would change that next day is that 12, you split that in half. So half of 12 is 6, so you're going to give 6 units as a long-acting insulin, and the remaining 6 units you'll give them TID as a short-acting insulin, and 6 by 3 is 2, so you're going to give 2 units TID of insulin. So to recap again, let's say the patient got 12 units of sliding scale insulin, and you did not put patient on any long-acting or short-acting on day 1, then the subsequent day you will give them 6 units of the long-acting insulin at night and 2 units TID of the short-acting insulin. I hope this makes it clear. Thank you for watching my video. If you have any questions or comment, you can post it below. Thank you again.